Welcome back to Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We are an affiliate of Physicians for a National Health Plan Kentucky. We're really happy to return to the airwaves here at Forward Radio, WFMP 106.5, and we're proud to be a community partner with Forward Radio. Single Payer Radio is part of the public affairs programming here at Forward Radio. We aim to raise awareness about the dire health and financial consequences of the current profit-driven healthcare system. Corporate media fails to cover or distort many of these issues. That's why community media matters. Kentuckians for Single Payer Healthcare and Physicians for a National Health Plan advocates for an expanded and improved Medicare for All system. Single Payer Radio provides a platform to explain why and address the myths and distortions by the status quo profiting from the current system. I'm Mark McKinley, a volunteer with Kentuckians for Single Payer Healthcare and a sustaining member here at Forward Radio. If you can, please become a sustainer. It's easy. Go to forwardradio.org and click the donate button. $5, $10 a month, it all adds up. As a matter of fact, we're celebrating our 3rd birthday on the air. It's all volunteer community radio, so become a member of the Forward Radio community. forwardradio.org. For the moment, Single Payer Radio can be heard in the Community Access Hour time slot the last week of the month. That's the 4th Wednesday of the month at 2 p.m., the 4th Thursday of the month at 11 a.m., and the 4th Friday at 1 p.m. To get a reminder about the program, sign up for our twice-monthly news updates from Kay Tillow, our chairperson. Go to kyhealthcare.org and stay up to date on Kentuckians for Single Payer Healthcare and Single Payer Radio. The views and opinions expressed on Single Payer Radio are those of the speakers and not the station. If you have comments about the show or would like to share your healthcare story, please send a note to Kay Tillow. She's our chair, as I said, and Kay's email is nursepo@aol.com. That's nursepo@aol.com. We're recording today's program in our Hayburn studio. It's April the 10th, 2020. That's Good Friday for the Christian community, but for millions of Americans, it's another grim Friday. A staggering 17 million workers have filed for unemployment in the past 3 weeks. According to Physicians for a National Health Plan co-founders, Doctors Stephanie Woolhandler and David Himmelstein say, quote, "Our healthcare system faces a storm unlike any we've seen before." Let's listen to what our guests have to say. Dr. Michael Flynn was a surgeon for 49 years, specializing in oncology surgery. He received his medical degree in 1962, and his practice has centered in urban areas that included not only private and academic clinical practices as well as medical practice in the military. Dr. Flynn had been associated with Norton Hospital and University Medical Center. His most recent articles appeared earlier this year in the February and March editions of the Louisville Medicine, which is published by Greater Louisville Medical Society. And you can see Dr. Flynn's article if you go to our website at kyhealthcare.org or on Facebook. Dr. Eugene Shively graduated from the University of Louisville and served as a fly surgeon in the Air Force for 2 years. He did his residency in surgery at U of L and was in private practice from 1979 to 2005. Dr. Shively then became an employee of Taylor Regional Hospital, which is about 80 miles or so south of Louisville, if you know where Campbellsville is. Dr. Shively is also well published. Both Dr. Shively and Dr. Flynn are emeritus professors at the University of Louisville Department of Surgery. Welcome, doctors.
Thank you.
Well, thank you.
You guys have been writing about this issue for some time. In general, if we could look at it from a broader standpoint, how did you become involved in looking at this issue?
Mark, let me just, as the first statement, make a disclaimer that my views on these issues that we'll discuss today are my personal views and do not in any way reflect the views of the Department of Surgery, where I was employed for a number of decades, or the University of Louisville.
My views are also my personal views and don't reflect the Department of Surgery at the University of Louisville, nor do they reflect Taylor Regional Hospital.
Okay, good deal. Thank you, Dr. Shively. So who wants to start? Dr. Shively?
Well, I actually got interested in medical economics when I was a resident. Dr. Pope one day made a comment that that medical economics is different than ordinary economics. He nor I can remember the guy who wrote this, but it was in the New York Times, and he was an economist. And if GM has too many cars, they reduce the cost to the consumer, and the price goes down. But if a hospital here in Louisville buys a very expensive equipment, and maybe there's only 2,000 or 3,000 people who need it, and another hospital system buys it, the price goes up in order to pay for the equipment. So from that point on, I was kind of casually interested in the cost of medicine. And through my lifetime, I've seen medicine go from a profession to an industry. And there were two events that happened here in Louisville that contributed to that. Extended care started in the 60s, which was a for-profit nursing home business, and it extended to 1972 when the extended care was sold, and they formed Humana as a hospital industry. And from the Humana, almost all the for-profit hospitals evolved. Humana is now an insurance company, although they do have some clinics that see patients. The other thing that happened was that there was an attorney here in Louisville in the 80s who was advertising on the benches around the courthouse. The Louisville Bar Association challenged that, and it went all the way to Supreme Court. There was a case in Arizona and a case in Ohio long before that. The case in Arizona was in 1978. And the long story, make it short, is that the Supreme Court said that you can advertise. So I went from a kid to a doctor to a residency where medicine was a profession, and it's involved in my lifetime and also Dr. Flynn's lifetime into an industry. And I define a profession as a group of people in Western civilization. It's usually been priests or ministers, lawyers, and doctors who provide service for other people that they cannot provide for themselves. For example, my family was in the jewelry business from 1910 to 1978, and we provided a phenomenal amount of service. We had a fantastic jewelry store in Campbellsville that reached out to the surrounding communities. But our main purpose was the profit. Well, we provided huge amount of service. Well, as a professional, I was different. If somebody shows up in the emergency room at 3 o'clock in the morning, my job is to take their appendix out if it needed to be, regardless of their ability to pay. And that distinguishes from a business or from a profession. But we have evolved now into an industry where profit is a really big modifying and really important in medicine today. Well, since I retired, I became more interested in medicine as an industry, and it's become a big political issue. Some people think it will be the #1 issue in the general election next November. And I started looking into it, and to my surprise, I found out that there's a huge waste in medicine. We spend approximately $3.6 trillion in medicine today, and I have come up with gross numbers that shows that we could probably save a third of that, perhaps $1.4 trillion. But very few people talk about that. Most of what I hear on the news is that we're going to get most of this money from taxpayers and from the federal government. I think we could save a phenomenal amount of money by doing some things that we're wasting in America. America is the richest country in the world, but we're the only country that does not treat medicine as a service, as a commodity, like a fire department or a police department. And the rest of the world spends much less money on medicine, and our results are not that good. If you look at the richest countries in the world, and there are about 35 of them, they're called the Organization of Economic Cooperation and Development Nations, the OECD. We're only about 15th as far as actual medical care, as far as life expectancy and morbidity and mortality. Our infant mortality rate is very high compared to those other countries, and the amount of money we spend is, for most of those countries, is at least twice as much as they spend, and yet they provide outstanding medical care. So that's how I got interested. I've been studying it. I have to admit that the numbers I have are a moving target, and it's very hard to get accurate numbers. So there's a disclaimer there, and it's changing, and with this epidemic, it's grossly changing. Mike, what are your thoughts on this subject?
Yeah, I came at this from I guess, a little different perspective. In the early 2000s, I had operated on an older gentleman who I guess would be about my age back then, who had some skin cancers. And I'd taken the skin cancers off, and he and his wife had come in. I was taking the stitches out, and we were chatting the way you do in this situation. And his wife started to cry. And after I got the stitches out, we just chatted for a little bit. And these were people from Western Kentucky. They had some kind of agricultural activity. I don't remember if it was a potato farm or a pig farm. and they had a lot of health problems, and they were facing medical bankruptcy. And we chatted about this, and it was just for me, it was a terrible example of two people who had spent their entire lives working hard. They had this very small rural business. They had limited resources, and they they had health care, but it was just really poor quality health care, and they were facing bankruptcy. I mean, I don't know what the end of the story was because that was a long time ago. I moved on to other things. But that got me interested in the for-profit health insurance companies because that was that the discussion that we had, I realized how much they were paying and how little they were getting for the policy that they had. And I hadn't paid much attention to this. I was busy with my career and families and doing all the things, and somebody else in the office was taking care of all this. And I had written a bunch of articles for Louisville Medicine after that, and as time went on, I sort of came to the same recognition of how this system has changed as you did, except I took a different avenue. From my standpoint, I'm looking at, if you look at the fundamental question, well, what is health care? Well, as you mentioned, Gene, and as an industry, and healthcare in this country is considered a commodity, like the food that you buy at Kroger's or the gas you put in your car to make it run or the shoes you wear. And most of the rest of the developed world considers it an essential public service and a government responsibility. And as you mentioned, there are a number of countries who have done a much better job with this than we have, and they're European countries, the Scandinavian countries. You mentioned 35 different countries, France, Germany, Canada, New Zealand, Australia, Taiwan, South Korea, Japan, the list goes on. These countries are all market-driven economies. They all have figured out a way to do this that are similar but different, and they haven't gone broke.
Dr. Flynn, something that struck me in one of your articles that you write that before Blue Cross Blue Shield became a for-profit industry in 1994, 95% of the revenue was spent on healthcare cost, 5% on administrative cost. And then when Blue Cross Blue Shield became for-profit, the administrative cost exploded to 20 to 35%. I mean, how did they justify that to their customers? That's astounding. I had not seen that.
This was a kind of a remarkable. This was an evolutionary process that began back in the early 1950s, when I think it was. I'd have to go look. So it was Cigna, and I can't remember what the other company was. They both started to sell health insurance, and Blue Cross and Blue Shield was a not-for-profit. They took everybody, regardless of your health care status. Everybody paid the same, and they got the same services. Over the course of time, from the 1950s to the 60s to the 70s and 80s, the for-profit health insurance companies slowly took bits and pieces of the marketplace. They provided different services for different levels of health care, and for different cost. So if you were a young, healthy person who wasn't going to use your health care, you got a cheap policy that didn't cover very much. And if you were older, you ended up with a more expensive policy because you were going to use up a lot of resources. And the sort of the death knell came in the mid-'90s when Blue Cross and Blue Shield, the not-for-profit that had a 5% administrative costs, finally threw in the towel. They became WellPoint, And along with all of the other for-profit insurance companies, the administrative cost then exploded from 5%, or Medicare has 2%, to 20, 25, or 30%, or whatever they could get away with in whatever market they were in.
Dr. Shively, I appreciate your practice in a more rural community. Can you give us some insights into how folks have dealt with, number one, rural hospitals, but also just the patients that you're seeing there in Taylor County?
Well, we attract patients from the surrounding counties. We've got a drawing area of about 100,000. In the last few years, though, rural healthcare systems have been in big trouble. Last year in 1919, there were 19 hospitals that went under, were closed. And I just read an article yesterday that the Kaiser Family Foundation is anticipating that about a fourth of rural hospitals could go under this year. Now, a lot of people might think, well, why do we even need rural hospitals? Why don't we just transfer them to, in my situation, to Louisville or Lexington? They're only 90 miles away. Well, my experience has been that if you don't have these facilities, there are a lot of people who just won't get care. And I'll give you an example. We have been very fortunate in our hospital that we're the oldest level 3 trauma center, and we're also have a fantastic cancer center. And I started working on cancer in the late 70s, in 78, 79, and we started giving chemotherapy in the emergency room. And with a lot of hard work, we've developed a cancer center with chemotherapy and radiation, and we are able to provide most of the surgery. Complex things like bone marrow transplants or liver resections or pancreatectomies, we send to UK or U of L. But as the result of our cancer center, we have people that we can take care of at home, and they much appreciate that. I have patients that don't have $20 to drive from Columbia to Campbellsville, and this is really important. We used to transfer patients from Campbellsville to Louisville for radiation, and we had a van service. Well, we got the job done, but the problem was we had patients who were sick, who were nauseated. They would drive to Louisville. Each one of them would get their radiation, and then they would come back. And that was a kind of a terrible experience. They would also sometimes get chemotherapy. And that just wasn't satisfactory. If you can provide the service locally, you really provide a great service. Now, things in my area of the state have changed radically in the last few years. When I first came there in the late 70s, we had a thriving hospital in Lebanon, which is 20 miles north. We had a thriving hospital in Greensburg, which is named Jane Todd Crawford Hospital, after the famous lady who was operated on in 1810 by Ephraim McDowell. And we had a thriving hospital in Columbia. All those surrounding hospitals have gone downhill, and we are essentially providing a lot of the acute care. The one in Columbia is essentially a emergency room. They see a few patients. The one in Greensburg, Jane Todd Crawford, is essentially taking care of long-term care patients. And the one in Lebanon is essentially doing outpatient services. And so we are still viable and still doing a good job, but it's really been hard. And the finances and taking care of patients in a rural area has really become a big problem. We don't. For example, if I do an appendectomy in Campbellsville, I get paid less than they do in Louisville or even at Hardin Memorial in E-Town. So that creates a financial situation that's hard for us to deal with.
Let me just say
Sure.
real quickly to let our listeners know, this is Single Payer Radio on WFMP 106.5 Forward Radio with our guests, Dr. Michael Flynn and Dr. Eugene Shively. Yes, sir, Dr. Flynn.
Yeah, Mark, what I'd like to do is kind of bounce back a little bit to one of the earlier issues that I'd mentioned, the comparison between a commodity and an essential public service. And just let me go through a few examples of the ways that other countries have figured out a method of providing some form of universal health care or safety net programs for the citizens in those countries without going broke. So first example is the United Kingdom. 1948, they established a national health service, universal health care. It's funded by general taxation, and they do everything. They run the doctor's offices, they run the hospitals, they run the pharmacies, they run the health supply issues, the whole ball of wax. And if you want to have private health insurance, you can get it. Canada, our northern neighbor, established a taxpayer-funded health care plan in 1984. Again, private insurance is available. In the Canadian system, their costs cover the physician and hospital costs, or the services cover the physician hospital costs. For other aspects of healthcare, dentistry, drugs, hearing, the individual Canadian citizens either have to get some other kind of insurance, private insurance, or they have some sort of employer plan. And this is a system that's kind of shared by the central government, who provides the resources, and the provinces that run the system. Australia, 1984. Universal health care coverage. The funding comes from multiple sources, national, regional, and private health care is available in Australia if you want it. Japan, 1961. Again, universal coverage, multiple funding sources. Some of it comes from the employer, some of it comes from the employee, some of it is out of pocket. There are no for-profit hospitals. Health insurance is mandatory. And Japan, and the healthcare fees are regulated. And Japan went through a 10-year, a decade transition from the kind of crazy market-run healthcare system that we have in this country to their system. Just two more examples. South Korea, 1989, universal national health insurance. It's compulsory. Again, multiple funding sources. South Korea has a surcharge on tobacco that pays for 5 or 6% of the health care coverage. And then my last example is Israel. Established a universal coverage in 1995. It's medical insurance is compulsory, and if you want to, you can increase your medical insurance, or you can have some private insurance in addition to that. So all of these countries, and there are other examples. I don't want to spend the whole hour talking about this, but I think this can be done. And it can be done in a way that is good for the citizens of the country and most of the providers. We've had people in the surgery department who were from Israel. They've gone back. They practiced there. I've got a good friend up in Canada who's very comfortable with the the way the system works. They get paid quickly, they get paid reasonably, and they provide a good service.
Let me
Dr.
just
Shively, yes, sir.
mention the German system. In the German system, it costs about 7.5% of what somebody makes, and half of that's paid by the employer and half is paid by employee. It's mandatory insurance, and the employee can select from various non-for-profit insurance companies, and everyone has to be covered. If you're destitute or disabled, then the government will step in and subsidize that. Everyone gets covered. If you want private insurance, you can have it. Private insurance usually covers things like private rooms, skip the line. You know, it's very common in Europe to have skip the lines. Even if you're going to the Vatican, you can buy a ticket where you don't have to wait in line. So that means if you need a total hip, you could probably see an orthopedic surgeon before everyone else. But everybody's covered for basic needs, and everybody seems to be happy, and everybody gets the medical care that they need. And it costs about half as much as our insurance. Our system is paying about 18% of the GNP. That represents the 5th largest economy of the entire world. And this year, it's probably going to be more than the entire GNP of Germany itself. So it's a huge economy, and it's something that we're going to have to deal with, particularly in this epidemic that we're involved in right now, which is affecting the whole world. Are we going to be able to continue to pay what we are doing right now? One of the other things I want to discuss, Mike brought up this thing about Blue Cross Blue Shield, and it's called the loss ratio. And for example, Medicare only spends about 2% of its money on administrative deals, but most for-profit insurance companies are spending 20 to 30%. And that means that money is going to the stockholders and for administrations and executives, etc. Now, don't get me wrong, I like to make money. I think money's great, and I even hoard it. But I don't think the sick folks, the money they pay in their premiums should go to stockholders. I think it should go to pay for their illness. And if the company is making money, then that money should be diverted back to lower premiums or other benefits for people who are ill.
Dr. Flynn, you had a comment about that skip the line?
I did, but let me, I would agree with Gene. I would just take it a step further. I think it's immoral what they do. We can talk about that some more later. Let me tell you another story about just a personal encounter about Switzerland. My wife and I were out in Crested Butte last September. Colorado. It's a small town, a ski town in the winter, and a mountain biking town the rest of the year. And after dinner, we had walked down the street to a little bar where there were a couple of guys with a couple of guitars that were sort of howling at the night. And I sat down at the end of the bar. And Karen goes off to the bathroom, and I'm sitting next to this guy, and I'm trying to look at the menu, and decide, and he sort of passes his drugstore glasses over at me, and we got to talking. This guy is probably in his mid-50s, and he was from Switzerland, and he was over there with a trailer that he was living in and a mountain bike, and we got talking about health care. So he took his wallet out and he showed me a card. This is the Swiss insurance card. That's like the Medicare card that we've both got, and whatever other things. I've got TRICARE as well. And he was telling me that, because I asked him, kind of a little bit old to ride the bicycle down the mountain. So what happens? Well, he apparently, with the Swiss coverage, if he had a serious injury, his Swiss health care insurance would have him evacuated back to Switzerland. That covers the transportation to get him back to Switzerland to get health care. And Gene and I had talked, I think, before you went to Honduras, and I said something about every time we go out of the country, it costs me $300 or $400 to get one of these insurance plans that covers all of the issues that may go on to travel, as well as health care, and especially the ability to get evacuated out of the country back here. So that's just another interesting example of how another country has figured out a way to provide good health care to their citizens by using all the money that goes into the health care system for health care.
The Swiss system is very similar to the German system. They take a certain amount out of your salary, and the employee pays a certain amount, and the employer pays a certain amount, and you get insurance, which covers everyone. And the government subsidizes people who are disabled or are elderly or have other problems.
Okay. I'd like to ask both of you if, as far as these other countries move to universal coverage for their citizens, was that a movement from the ground level as far as grassroots organizing, as something similar to Kentuckians for Single-Payer Health Care and others across the country are doing? Or did that come from the top with elected officials saying, no, this isn't right, and we're going to go in a different direction?
The only one I know for sure about is in England in 1948. That was something that the people wanted. Actually, Churchill was opposed to it, and if you remember, he got defeated. And it's hard to imagine a guy like Churchill got defeated, but the people wanted a socialized healthcare system, and he was opposed to it, and as a result of that, he was defeated, but they got the National Health Service. Now, I'm not sure about the rest of Europe.
Well, Gene, I think that in England it was a bit of both, because what was happening in England at the time was that they were being exploited by the insurance companies, just the way that's going on in this country. But I think it was a combination of the desire of the population to have better health care and have decent health care. It was terrible. And the fact that in order to get that, they elected a labor government. And, I think Winston Churchill is probably the best wartime leader that the world has ever seen. And I agree with Gene that he was on the wrong side of that apple. As well as I can figure out from looking at all of these issues when I put a talk together for Grand Rounds back in December, it's kind of a bit of both. I mean, I think in Australia, they put a government in charge that listened to the people who were complaining about the way health care was provided. In Japan, they started off with a lot of insurance companies running it, and over the course of a decade, they slowly went from one process to another to get to the point where they are today, where they have universal health coverage. So I think it's a bit of both, and I think the need and the desire to have decent health care, to not get cancer and go broke, is an important incentive. But in order to get the actual system in place, you've got to put people in in positions of power to do it. And that's not anything that's going to happen anytime soon in this country unless there's a major change in the political ruling class.
I do know that the German system dates back to the late 1800s, and they had some type of a medical system, and it's evolved since then. I'll look up the history of that and report to you next month.
Okay, good deal. And I want to remind our listeners that you're listening to Single Payer Radio on WFMP LP 106.5 Forward Radio. Our guests this afternoon here at the Hayburn Building are Dr. Michael Flynn and Dr. Eugene Shively, which I sure hope that this is the first in a series of conversations with these doctors to identify some of the important issues that our healthcare system in crisis, and the pandemic has really exposed many of the shortcomings of our system, as well as exposed the heroic men and women in the healthcare profession doing just unbelievable jobs. Dr. Flynn, in one of your articles, you talked about the numbers of people carrying medical debt in this country. Was it like 600 million people? Or I mean, it was just phenomenal.
Yeah, I don't have all that in front of me right now. The number of...
it's 64 million. I've got your article here.
Yeah, well, that's a combination of the uninsured and the underinsured. And the underinsured are generally people who have some kind of insurance that's probably not very expensive and probably doesn't cover very much. And they may be young. And this is fine. You're young and you're healthy and you're probably not going to use it. But if something bad happens, you get into an automobile accident and you fracture your leg and you puncture your lung, spend some time in the ICU, spend some time in the hospital, then you go into rehabilitation. You may or may not lose your job and you use your income. And the insurance plan that doesn't cover very much, and the for-profits were able to basically put a Blue Cross and Blue Shield, when it was a not-for-profit in the mid-'90s, out of business by cherry-picking all of the healthy people out of the system, by providing them with inexpensive plans that didn't cover anything, and that's what they went for. Whereas Blue Cross and Blue Shield, when they were a not-for-profit, were trying to cover everybody, and you've got to have a large group putting in order to pay for the costs of the care of the most needy and the most vulnerable. Let me just make a comment or two in a very broad sense,
please,
about for-profits, because if you think about it, from a business standpoint, it's a remarkable situation that they've been allowed to get away with. They are allowed to sell a product, health insurance, but not provide it. So the basis of revenue for the for-profit health insurance companies is the premium that is paid with the expectation of getting health care coverage. Now, they didn't invent a better running shoe. They haven't designed a more fuel-efficient automobile. They simply take the money, the premiums that are paid, and they don't provide the health care coverage. And they've done this by a very complex system of of steps that people have to go through in order to get health care paid for. The pre-authorizations, you've got the co-payments, the deductibles, and on and on and on. And there's the army, is an army of executives who work in the for-profit health insurance industry whose goal is to figure out ways not to provide health care. If you look at where the administrative costs go, well, a certain percentage of healthcare administrative costs are legitimately administrative. Then there's advertising. I mean, this doesn't go on in most other developed first world countries. Political contributions. I guarantee you that this wouldn't go on without political contributions. And then you have this outrageous executive compensation. Today, in an article in New York Times in 2019, the average CEO of a for-profit health insurance company is getting paid between $20, $30, and $30 million a year. That's just the top guy. And then you have this whole food chain of people below them that are also making huge amounts of money in order to figure out ways not to pay for health care. And then on top of that, as Gene mentioned earlier, they're giving money to investors. And then at the end of the day, actually paying for health care is called a medical loss ratio. So from a business standpoint, the for-profit health insurance company looks at paying for health care, which is the product that they're selling, as a business loss.
Dr. Shavli, comments?
Yes. We are the only country in the world that allows hospitals, doctors, and lawyers to advertise. Now, New Zealand allows drug companies to advertise, but we are the only ones that broadly allows people to advertise. When I was growing up, you never heard an ad about a doctor or a hospital on the radio or TV. Now, if you're watching the news, half of the advertisements are about drugs or about some profession. And direct marketing of some of these drugs to consumers is extremely complicated. They're advertising drugs that are very complicated that sometimes I have to look up the drug. I don't know what they're talking about. And they're also extremely expensive. Now, most places in the world, the consumer doesn't make a decision on whether he needs an expensive drug like that. It's a discussion between a doctor and the patient. For example, some of these drugs, only the specialist would even prescribe a drug. For example, somebody has Crohn's disease who needs a drug like Humira or one of the other drugs. These are complicated drugs. There are a lot of complications. I've seen a patient who died from taking one of these drugs who had Crohn's disease. These should be decisions not made by the drug company to the direct advertising. They should be made by a specialist who works in this disease and to the patient with an extreme informed consent. The amount of money that we spend on advertising is $30 billion.
Could save a lot of lives. And Dr. Flynn, what you're saying as far as the success is measured not by the number of patients the insurance company saved that day, but by the amount of dollars that they saved the stockholders. Is that
Well,
what-
no, the amount of dollars that they have not wasted on providing health care coverage. Now, this
Wasted,
this
yeah.
is insane when you think about it. This is an absolutely insane system that they allows these companies to sell a product but not provide it, and figure out all kinds of ways to use money for some other reason than actually providing the product that they're selling.
Well, what you're saying, it's kind of, it reminds me of some gangster movie as a protection racket. but I don't know. I'm just a regular
Well, the
working dude.
protection are the political contributions.
Yeah.
And
There's another thing
Yes, sir.
that's fascinating. My son's a lawyer, and he tells me that this would be illegal in any other commercial enterprise in the United States. There are drug companies who will actually pay a generic company for not putting their drug on the market, and it's legal to do that.
yeah.
So if I've got a generic drug that would be much cheaper, and another drug company's got another drug that's still on patent, they will actually pay this other company for not marketing it. And that's legal to do in the drug industry. We can spend the next 2 or 3 hours talking about the abuse in the pharmaceutical industry, and it's extremely complicated, and there's a lot of silos that nobody knows what's going on between the different silos. For example, pharmacy benefit managers, they control the market, and most pharmacists don't know what they're doing or how they do it. They make deals between the drug company and the big companies like Kroger and Walmart and CVS, and they make all kinds of deals. They get rebates, they get special deals, and sometime in the future I want to go into some of the difference in prices. This was just astounding.
Yes, sir. We've got about 4 minutes left. Yes,
I
Dr.
just want to
Flynn.
make
Sure.
one more quick comment. I agree with everything that Gene said about the pharmaceutical industry, but let me add to that. Medicare, the largest drug purchaser in the world, is prohibited by law from negotiating with the drug companies. Now, talk about a protection racket. I mean, this is the most insane political situation that you can imagine. In Canada, they have a Ministry of Health. The Ministry of Health has a drug review board. The drug review board reviews the drugs, the costs of the drugs. I mean, these are issues that I think that in the future we can spend a lot of time talking about. Just think about the insanity of the Congress of the United States passing a law that prevents the biggest drug purchaser in the world from negotiating with the drug companies.
But
Well, I'm sure it's passed in the middle of the night when there's no light
Well,
being
there's two or
shined.
three laws floating around now trying to get somewhere to stop that or
Yes,
amend
yes, sir.
it.
The
Dr.
VA
Shadley?
can negotiate with drug companies,
Yeah.
and the cost of drugs at the VA are much less. We are responsible for half of the drug bill of the entire world. That's a lot of money.
Yes, sir. Yes, sir. We've got just a couple minutes left. Can we end on something quickly? I'm sorry, and we'll have plenty of time to come back. But something positive, some trends that you see.
Well, I think the reason we're here is that we believe that the system needs to change, and changing the system is going to involve a political process. In my opinion, the best long-term system that we could put in place would be some form of a single-payer system. Now, having said that, whatever that would turn out to be would be the result of a political process. And just one example of what happened with a political process was the negotiations to get the Affordable Care Act passed allowed the for-profit insurance companies to keep 20% of the revenue passing through them is profit, and prevented the addition of some kind of public option added to the Affordable Care Act.
Yes, sir. Dr. Shively.
Last comment.
I think that we can save at least over $1 trillion, and with that decrease in expense, then adding to that with government resources, that we can actually make this an affordable system.
Yes, sir. Thank you, Dr. Shively, Dr. Flynn, for coming in, your work on this, and we look forward to the next time. Hopefully, we'll be able to come in under less social distancing activity soon, but I think it's going to be with us for a while. Let me just say that Kentuckians for Single-Payer Healthcare is suspending its regular meetings during this period. You can learn more about the group and get involved by going to kyhealthcare.org or follow us on Facebook. Single Payer Radio is currently heard monthly, the fourth Wednesday of the month at 2 p.m., fourth Thursday at 11 a.m., and the fourth Friday at 1 p.m., and we'll get this up on the Forward Radio SoundCloud. If you like what you hear on Forward Radio, WFMP LP 106.5, please support our volunteer-driven community radio station. Go to forwardradio.org and become a member of our community. For Single Payer Radio, I'm Mark McKinley. Healthcare is a human right. Stay safe, everybody.